Welcome back to Anatomiqa. In this session, we will be discussing the details of congenital anomalies of face. The learning objectives of this session are: describe the developmental basis of congenital anomalies of face and palate. The normal development of the face is discussed in another session. Please watch it before you proceed. Now going to the anomalies. Anathia means absence of mandible. This is always associated with otocephaly. Since it is associated with otocephaly, it is also known as anathia otocephaly complex. It is a very rare and lethal cephalic disorder characterized by the absence of the mandible, which is called as anathia, which is associated with the ears, which are fused together just below the chin. It is caused by a disruption to the development of the first branchial arch. So this anomaly occurs in every 1 in 70,000 embryos. So that is the incidence of anathia. The congenital anomalies of face are mainly the facial clefts. A facial cleft is an opening or gap in the face or a malformation of a part of the face. Facial clefts are a collective terminology given to all types of clefts. Any structure like bone, soft tissue, skin, etc. can be affected. There are many types of facial clefts. Let us look at few of them one by one. Oblique facial clefts or orbitofacial fissures. They are often bilateral. The fissure extends from the upper lip to the medial margin of the orbit. It is produced by failure of fusion of maxillary prominence with its corresponding lateral nasal prominence or process. When this occurs, the nasolacrimal duct is usually exposed to the surface and is called persistent nasolacrimal groove. Lateral or transverse facial clefts are placed horizontally and run from the lateral angle of mouth towards the ear. This is produced when the maxillary and the mandibular processes or prominences fail to fuse normally. So the size of the mouth depends on how much fusion has taken place between the maxillary and mandibular processes. When the fusion of the maxillary and mandibular processes occur partially only near the posterior end and does not extend further anteriorly, it leads to large mouth called macrostomia. So that is Mr. Chidanand, a famous Kannada actor in small screen, who has macrostomia. In some individuals, due to overfusion of the processes beyond normal, it leads to small mouth. This is called microstomia. Cleft lip and cleft palate. They are the most common defects that result in abnormal facial appearance and difficulties with speech. The incisive foramen acts as a landmark and divides the palate into anterior and posterior parts. Based on this, the cleft anomalies are classified as anterior and posterior cleft anomalies. Coming to the anterior cleft anomalies, the defects anterior to the incisive foramen include lateral cleft lip, cleft upper jaw, and cleft between primary and secondary palates. Such defects are due to a partial or complete lack of fusion of the maxillary prominence with the medial nasal prominence on one or both sides. The posterior cleft anomalies. The anomalies that lie posterior to the incisive foramen include cleft palate and cleft uvula. Cleft palate results from a lack of fusion of the palatine shelves, which may be due to smallness of the shelves or failure of the shelves to elevate, or inhibition of the fusion process itself, or failure of the tongue to descend between the shelves because of micrognathia. The third category is the anterior-posterior cleft anomalies, which includes the clefts lying anterior as well as posterior to incisive foramen. That includes various types of cleft lip and palate and cleft uvula. Anterior clefts vary in severity from a barely visible defect in the vermilion of the lip to the extension into the nose. In severe cases, the cleft extends to a deeper level, forming the cleft of the upper jaw, and the maxilla is split between the lateral incisor and canine tooth. Frequently, such a cleft extends to the incisive foramen. Likewise, posterior clefts vary in severity from cleavage of the entire secondary palate to cleavage of the uvula only. Unilateral cleft lip. The unilateral cleft lip results from the following: maxillary prominence on the affected side and the merged medial nasal prominence fail to unite with each other, leading to the fissure. The tissues in the persistent groove break down, leading to division of upper lip into two parts. Bilateral cleft lip. In bilateral cleft lip, the mesenchymal masses in both right and left maxillary prominences and the merged medial nasal prominences fail to fuse. When there is a complete bilateral cleft lip and the alveolar part of the maxilla, the intermaxillary segment hangs free and projects anteriorly. In the cases of cleft lips, there is a discontinuity in the orbicularis oris muscle. Median or midline cleft lip. It is a rare abnormality. Midline cleft can occur in the upper jaw, called midline cleft or upper lip, or in the lower jaw, called midline cleft of lower lip. In the midline cleft of upper jaw, the two medial nasal prominences in the midline fail to fuse, leading to midline fissure. In the picture, only a small segment of medial nasal prominences have not fused, leading to midline fissure in the upper lip. The median or midline cleft lip of lower lip is very rare. So here the mandibular prominences do not fuse, leading to the midline cleft lip of the lower lip. The picture shows the midline cleft in the lower lip. Cleft palate. The frequency of isolated cleft palate is lower than that of isolated cleft lip. The incidence of cleft palate is 1 in 1500 to 2500 births. It occurs more often in females than in males. The reason may be, in females, the palatal shelves fuse approximately 1 week later than in males. The cleft may involve only the uvula, giving it a fish tail appearance, or it may extend through soft and hard regions of the palate. In severe cases, the cleft palate associated with cleft lip extends through the alveolar part of the maxilla and the lips on both sides. They are classified into three groups. Clefts of the anterior palate. It is formed because the lateral palatine processes or the palatal shelves and primary palate do not fuse with each other. Clefts of the posterior palate form because the lateral palatine processes and the nasal septum do not fuse with each other. Clefts of anterior and posterior palate are formed because the lateral palatine processes and the primary palate and the nasal septum do not fuse with each other. This slide is showing how the cleft palate defects are seen in frontal view and from inside of the oral cavity. The picture on the left is of the normal development. The middle picture is showing the unilateral cleft palate and lip, and the picture on the right is showing bilateral cleft lip and palate with cleft uvula. The causes of cleft lip and palate are not well known. Some of the causes are as follows. Most clefts of the lip and palate result from multiple factors called multifactorial inheritance. Then defects in the neural crest cell migration. Some cases are associated with certain syndromes and genes. Exposure to teratogenic compounds during pregnancy, such as anticonvulsant medications, particularly valproic acid. Cigarette smoking during pregnancy also increases the risk of having a baby with orofacial clefts. So this completes the topic on congenital anomalies of face. Thank you for watching till the end. If you like the video, like, share and subscribe to the channel.